Hello, everyone. Thank you for joining us for this session on the role of media and communications in building public confidence in the COVID-19 vaccine. We will now begin the session, but just a few reminders to please keep your microphone muted if you are not speaking. You may ask participants questions throughout the session using the chat box below. We will have a Q&A session at the end of the webinar. This webinar is being recorded and will be provided to registered participants after the session and will also be available on Core Group's website. I will now hand it over to Lisa Hilme to begin the session.
Good morning, everyone. Good afternoon. Welcome to the webinar. My name is Lisa Hilme. I'm Executive Director of Core Group, and I'm a nurse. I also sit on the ECAVI Vaccine Alliance Civil Society Organization Steering Committee and co-chair the NGO constituency at the Partnership for Maternal, Newborn, and Child Health at WHO, or PMNCH. I hope that you and your families are safe during this COVID-19 pandemic. I'd like to draw your attention to the closed captioning button on the bottom of the Zoom. If you'd like to enable closed captioning, you can click on that. We are able to offer this series and subsequent activities through a medical education grant from Pfizer and Core Group funding. Today, we're going to have a dynamic conversation on the role of media and communications in building public confidence in the COVID-19 vaccine. The first episode of Core Group's Vaccine Confidence live webinar series, Protecting Communities by Transforming Vaccine Hesitancy to Vaccine Confidence. As you know, there's an infodemic of information and misinformation circulating about COVID-19 vaccine safety and efficacy, reducing the public trust in really getting vaccinated. The media and other communications play a critical role in providing this vital health information to global and country-based audiences. Our panelists today will discuss their organization's strategy for increasing COVID-19 vaccine confidence and addressing the misinformation through mass media. First of all, a couple points. Today's webinar is being recorded and live streamed on both Zoom and Facebook Live. We ask if you're not speaking to mute yourself. I can hear a little rumbling right now, so if you can please mute yourself. Recordings will be made available later on the Core Group website, Facebook, and YouTube. Second, a little bit about Core Group. Core Group convenes global health practitioners to share knowledge, evidence, and best practices, and then translates these into the real world with a direct impact. We believe in inclusive approaches to our work for women, children, adolescents, people with disabilities, people of color, the hardest to reach, the LGBTQ community, youth, and many more that are underserved. Core Group has worked for almost 25 years to advance the field of community health through collaboration by developing case studies and analyzing research, creating training curricula, developing monitoring and evaluation training, hosting annual conferences, and advocating for community approaches to health. Core Group has more than 15,000 people and organizations among our members and larger networks with a reach of over 250,000. Look on our website, coregroup.org, for more information on how to become a member and sign up for our working groups. Since February 2020, Core Group has been at the forefront of convening stakeholders to promote vaccine equity at the global, country, and local levels, and addressing the many challenges of the COVID-19 pandemic. We've had 3 Lives in the Balance Summit. Please look on our website. They were amazing conferences, which really focused on COVID-19 crisis and its impact on women, children, and adolescents, and vaccine equity. Our Global Health Practitioner Conference took place in January, which was fantastic, on child and adolescent health. Again, on our website, take a look, it was free. COVID-19 Virtual Marketplace, which is an online platform to connect in real time the needs of local communities with the appropriate resources like PPE, like training to prevent and respond to COVID-19. We have a COVID-19 resource library and many, many webinars. So please have a look. We've been extremely active also in global advocacy to promote equitable distribution of the COVID-19 vaccination and share your work. We work closely with global and country partners and share COVAX updates with our networks. Look for more information for next week's Civil Society COVAX update on Tuesday, June 29th. We'll be circulating information about that soon. In all of our work, we strive to center the voices of community leaders in their local contexts around the world. We look forward to hearing from our panelists today about how they, as media and health leaders, have worked together to promote vaccine confidence. And right now, I'm going to turn it over to our moderator, Dr. Ben Bellows, co-founder of NIVI Inc., a core group member. Ben, over to you.
Lisa, thank you for that introduction and its introductory remarks. And it's great to be here today to join this esteemed panel in discussing an incredibly pertinent and pressing issue around the role of digital and media in fostering a positive environment that encourages vaccine awareness and vaccine confidence. So it's my pleasure today as co-founder and chief business officer at NIVI, a company that's been dedicated, a consumer-facing digital health company that's dedicated to engaging consumers on reproductive health and maternal health topics, and recently around questions of vaccine confidence, to present and moderate a panel with others who have been really diving deep into this topic with a wide breadth of experience and perspectives on the role of communication and media and boosting confidence. So without further ado, we've got three panelists who will give us their perspectives on different elements of vaccine confidence. You'll hear from each of them. And then we'll have an opportunity for questions and answers following the presentations, about 20 minutes at the end of today's panel. So looking forward to a healthy conversation, a rich conversation as we dive into this topic together over the next hour and 20 minutes. So without further ado, I'd like to introduce our first panelist, Dr. Umbeva Malandi. He's the, excuse me, I'm gonna pull up my notes here and get this right. Calling in from Nairobi, from Kenya rather, and he's there we go, the director of the East Africa Center for Vaccines and Immunization. He's a vaccinologist and senior consultant in pediatric infectious diseases, and has a rich background in this area around vaccines and immunizations at the population level. So without further ado, Dr. Umbeva, if you'd kindly lead us through your presentation. Thank you.
Thank you so much for the opportunity to be able to participate and share in this meeting. Let me just put up my slides, and I request that you be able to inform me if you are able to see my slides.
Yep, they're coming through. Now maybe we could go into the presentation mode.
That's what I'm doing now.
There we go. Excellent. Thank you.
A minute. Fine. Oh, sorry, just a minute. Okay, so it's good. It had gone up to the last slide, but okay. So thank you so much. I'm really honored to participate in this particular presentation today. And as the co-panelists mentioned, I'm called Umbeva Malandi. I teach at the university. I'm also a research associate in a university in Pretoria called Sefako Mahato University. I do teach in East Africa in Egerton and Makerere universities, and I'm also a pediatrician by training, specialist in pediatric infectious diseases, and a senior consultant and vaccinologist. And as part of this work, we do have an organization called the East Africa Center for Vaccines and Immunization that basically works in 6 East African countries and 11 Horn of Africa countries. And basically what we do is training, research, advocacy, and supporting health systems in these particular countries. It's important to also mention that we work very, very closely with the ministries of health in these particular countries and with the associations, the medical and pediatric associations, because we are more of a health leaning body. And for that reason, today, I think I'll be wearing more of our advocacy and training caps, which relate to basically the issues that we are discussing today. Over the recent years, the increase in uptake of social media in our region and in East Africa, it's necessitated the need for organizations like ourselves to adapt, to be able to reach majority of the communities and at least those that are on social media to be able to reach them. And so one of the things that we've done, training, and especially in the era of COVID-19 and since the last 1 year or so, we've intensified our communication to schools, to banks, to institutions, to organizations, to associations. And the reason is because the ability to be able to host online meetings and conferences and webinars has given us a very unique opportunity to be able to reach a lot of organizations. And one of the things we do is that not just do we do this, because we made up of about 20, our board consists of about 20 experts in the region. And each one of them has different areas where they're participating in. And so we do either joint or individual activities that promote correct information and try to promote correct messaging to the public and to institutions, and just to guide the messages. The reason is because in our region, and like in Kenya, for example, very recently we had a lot of problems with the uptake of some vaccines because of a lot of hesitancy and false messaging, both from anti-vaxxers and also from some reservations that the church, particularly the Catholic Church, had. So those are areas where we have to come in and try and find a common ground where then the correct messaging can be relayed, and whether it be that there were issues, then those issues could be resolved. One other thing opportunity that we have used a lot is our training sessions. Each year we host what we call the vaccinology course that attracts audience from almost 15 to 20 countries, mainly targeting African countries. This week we're actually running the 7th edition of that course, and it ends tomorrow. And so far we have attracted about 120 health workers. So these are health workers at managerial level and mid-managerial level who are interested and who are participating in issues about vaccines. And so we take them through a 1 week of a training, basically just to equip them. And previously, our trainings focused more on health systems and how they can improve their health systems, and also vaccine science and available vaccines, and just imparting them with knowledge. But last year and this year, we have modified the course a bit more to talk about issues about advocacy, issues about communication, issues about engaging communities on issues that relates to immunization. Our bigger goal, of course, being that if we can engage them and train them well, then we can make them champions so that they can become advocates, not just for vaccines, but even for safer health and safer child health. So we are using this particular course alongside opportunities that we get during annual scientific conferences to relay this message. Of course, we've also learned now that just like every other organization you'd imagine, to leverage the presence of social media and see how we can be able to use this as a tool to communicate and as a tool to disseminate, because all these opportunities offered by Twitter, offered by WhatsApp, offered by Facebook have provided for us an interesting chance to be able to reach as many people as possible. One of the biggest challenges in East Africa is mobility. And some parts are very hard to reach, some parts are hit by conflict. If you see, like talk of Somalia, for example, and the South Sudan. So others are still very poor in terms of infrastructure. And then the very issue of costs, because we mainly are funded by either money or from grants that we get, or from support from institutions that we collaborate with. So if you do not have a lot of funding to travel and go and pass the messages you need to pass, So we've been able to leverage this particular aspects of social media to be able to move our message forward, because for us it has offered us an opportunity to be able to reach governments, to be able to reach professional bodies, and to be able to pass our message. And now we are even involved right in the middle of planning meetings with different government institutions that deal with immunization. Because now it's very easy for them to just involve us through online virtual platforms, where then we don't need to travel. And that has helped. So COVID-19 has opened that door, not just elsewhere in the world, but in East Africa as well. And last year, I think about 2 years ago, Facebook contracted me as one of their consultants to help in terms of developing content and how we can correct content on immunization. And I've actively, myself and a few of my colleagues here, played a big role in helping the information that goes out on Facebook pages and doing those surveys that they do for information that relates to immunization and that relates to COVID-19, and also being able to sieve out whatever people post. So one of the things that we do is that we've helped Facebook to come out and design tracking and identifiers for information that may be false, that may need verifying. So you must have seen already, if you're on Facebook, that if someone posts something that is offensive or that is untrue, they put kind of a blind on top of the message, and sometimes it's not seen. And when the message is very grossly misappropriated and is likely to have a very big negative impact on a large parts of the populations or countries, then what is done is that the particular account holder is warned about their, or rather, let's say, reminded about their responsibilities, so that subsequently, if that continues, then the Facebook accounts can be suspended for a while. And I think this has been now spread to WhatsApp, and I know soon, and even Twitter, I think, yeah, also does caution and warn against misinformation, because misinformation is harmful. We don't want a situation where we end up damaging work that has been done for so many years because of misinformation. In fact, one of the other recommendations that we made, and I realized it has been implemented, is when someone has a video that they upload on their Facebook page that is false, and then they're able to download it, let's say because Facebook has stopped it and they can't share it. If they're able to download it and they want to share it through, let's say, a platform like WhatsApp or Instagram, they won't be able to. That kind of video is flagged. So those are some of the areas which, in a small way, we have joined and worked together with other participants and other stakeholders to try and improve social media messaging, because largely majority of our audience now are on social media. What drives us is because historically, as you know, we had issues with myths around vaccines, some of them which were very false. Issues around MMR, as you know. Now in East Africa, we are faced with a lot of problems of claims that deal with COVID vaccines, that COVID vaccines can kill. If you get the vaccine when you are sick, you are likely to die. And this is the problem, because we are dealing with a disease that is 70% no symptoms. People don't have symptoms, majority of them. And so for our countries, we don't test first before we give the vaccine to people. We say that if you do not have signs and you're okay, you come get your vaccine. So it may be that you may end up vaccinating some people who are either incubating or carrying the virus itself. But you know what most of the groups that are against vaccines in our country have been doing is to tell people that, you're not supposed to get the vaccine. If you go for the vaccine, you're going to die. People went for the vaccine, failed, sick, and died. And so those are challenges, and we've been involved very actively. Over the last 1 month, I have held about 15 webinar series with the banks, with the churches, with the religious groups, not myself alone, but other board members and consultants of our organization, just trying to drum up the correct message. On our Facebook page, we have put up posts, put up messages that try to drive the correct message. And we've applied for a small grant. We are hoping if we can get that kind of funding, to be able to translate these messages into local languages. Many of the people in our area of operation, particularly in the 5 East Africa countries and 6 North Africa countries, use a lot of their own traditional and local ethnic languages. Our hope is that we can be able to transition the material, because it will help us in this particular phase 2 of our vaccine communication strategy, engaging the general population. We hope that we can engage communities by trying to translate these materials, what you call the IEC materials, information, education, and communication materials in local languages, and then be able to advise and instruct and be able to advise and guide the communities in languages that they can understand. So that's another thing that we are doing. We want to make sure that communities are mobilized to move alongside government with the message that government wants to give. Otherwise, we'll end up in a situation where the vaccines have been rolled out, but we are not moving together with the people in the community. So our health messages often, what we've seen in our experience, messages make people feel uncomfortable and stressed, because sometimes when you tell them about a vaccine, and there's been fears like what we saw with the HPV vaccine, where some anti-vax groups went and told people that if they get the vaccine, their girls will be barren. You know, they are going to, the vaccine itself will cause cancer. Yeah, the vaccine is supposed to prevent against the likelihood of developing cervical cancer. So we've had to go back to the communities, educate them, work with government, try and generate and prepare material that can be used for training of these particular people and communities. We work very closely with the WHO and UNICEF, not only just to prepare the material, but to be able to edit them, put them in local languages. We even go to radios. Recently, we worked with the Uganda Paediatric Association and went to local radios and made small short clips of messages, which then are played repeatedly on the airwaves in communities in their own languages. And this is going to help us because, you know, there's a lot of information that is being generated, and in the process, you end up with a lot of wrong information that is going out there, which, as most of you are familiar with INFODEMICS. And part of the issues that we face now is that with COVID-19 and with a lot of accessibility to internet by many communities, this is becoming a big challenge for disseminators of information. We realize that not only us, but many organizations are facing the challenge of even catching up with information. The information that is being released is so much. Sometimes I see vaccine information for the first time on social media, yet people call me and ask me about it, and even healthcare workers, and tell me, have you seen this? Do you know whether this is true? Yet I'm just seeing it for the first time. So the information is moving faster than we can, ahead of us, and the most important thing is that we need to be able to see how we can leverage social media to tackle infodemics and make sure that we are ahead of the game. It's likely not to be easy. It's going to be tough, but I think that many organizations should seriously think about not only training and equipping our staff about how to communicate, but we should also be able to train them on how to detect wrong messages. However subtle the wrong messages, we should train ourselves and equip ourselves on how to detect them and how to respond. For us, we have even made templates of information that we have available. And so when we see a false message, we look at our bank and say, do we already have a ready answer for this, or do we need to just edit it a bit, be it a poster or a graphic, and we edit it and send it out there, so that then people can be able to get corrections as fast as possible. The other thing that we are doing, apart from just being very careful, is to try and make sure that our messages are gentle. So we are not condemning, we are not abusing, we are not directing, we are not insulting, but that we are making sure that everybody can be able to get a message in a language that they understand. Because we think that everyone can be mobilized and be involved in fighting infodemics, whether it be the community, whether it be the general public. We build trust in them, teach them how to identify false information. But more importantly, try to show them where can they get correct information from. Because if we are sure and we know where they can get correct information from, then we'll not need to worry. All we need to do is to make sure that that information is available. Then when they reach to it, they can be able to participate responsibly in their duties in the community. So this are basically the areas in terms of a brief overview of what the East Africa Center for Vaccines and Immunization is doing as regards participating in dealing with falsehoods and false informations and infodemics and the challenges that it's portending in our world today. Thank you so much.
Dr. Mbeva, thank you. That was a fantastic presentation. As a scientist and a communicator, you bring a diverse set of skills to the field, and it's a pleasure to hear the range of levels and the number of levels at which you're operating. I think as a practitioner in the communication space, being a weekly columnist in a paper, for instance, is an effective way to practice what you preach, in a sense, to practice the communication of science, being able to communicate the results of science, but also the process to ultimately build that trust that you were speaking to throughout the presentation, that important role of being credible and informative to engender more effective discourse indirectly. That we're all influencers in a way, and so it's bringing that that story to others so they can share on within their networks. I thank you for your presentation. I'm going to move quickly to our next presenter, and then we'll have the Q&A at the end. So Marie Bonner is the global head of partnerships, at First Draft, which is a coalition dedicated to strengthening the quality of the news, in effect. So bringing a coordinating role to the improvement of the quality of information conveyed through journalistic channels. And so without further ado, I'd ask Marie to give a presentation and some insights on what she's seeing from her side with respect to digital communication and vaccine competence.
Thank you very much, Ben. I'm going to share my presentation. Does everybody see it?
Yes, it's coming through clearly.
Perfect.
Yes, we're able to see it properly.
Thank you very much. So many thanks for having me today. Many thanks to the core group team for the invitation and Ben for the moderation, but also Dr. Malande for this very interesting presentation. What I'm hoping to share with you today is how and why all along this year and a half of the pandemic, the scope of our work at First Draft adapted and shifted because of the pandemic evolution, but also because of the profile of the audiences we have been training and supporting during that year. Just to introduce myself, my name is Marie Bonner, as you said. I'm Global Head of Partnerships at First Draft. I'm French and German, so pardon my English, and I'm working on collaborations and outreach. So do not hesitate to get in touch with me after the session if you think that might make sense for your organization as well. If you're not familiar with us at First Draft, we are a global organization working to empower people with knowledge and tools to build resilience against harmful, false, and misleading information. So how do we do that? We do that by having a small but mighty editorial team in our 3 bureaus in the UK, in the US, and APAC to monitor online mis and disinformation narratives at global level as much as we can in various countries, with a special focus on health and vaccines since the beginning of the pandemic. We are also researching specific areas and case studies related to online information disorder, as I will show you later on in this presentation. We are also developing and delivering training and simulations of online information disorder crisis for media and expert organizations, including, for example, the UNICEF, the WHO, MSF, and others during this last year. And we are developing a global network at regional level as well of publishers and topic experts to tackle mis and disinformation together in a collaborative way. It is called CrossCheck, and it's also the name of a platform we are building and we hope to launch very soon. So before the pandemic started, and since 2015, we have conducted several collaborative projects between journalists, platforms, and academics, mostly around elections. So we were in France, Nigeria, Brazil, UK, US, Australia, Uruguay, etc. All of these projects taught us on how to approach and cover mis and disinformation in heated times when it comes to democracy and citizenship. Our collaborations with journalists, platforms, and academics also really anchored our editorial research and training work in verification, social listening, and responsible journalism. That is why when the pandemic started, our first emergency was to build a detailed online course for journalists covering coronavirus. So the idea was really to equip reporters with tools and techniques to deal with the uncertainty of the infodemic. This course, which we launched in 7 languages in March 2020, was very much focused on verification and fact-checking and covered the narratives and themes that we saw flourishing at the beginning of the pandemic, which were vulnerable to misinformation. So we are talking, for example, about the origin of the virus, the symptoms, the cures, the reaction of citizens, and the measures developed by authorities. We also complemented this course with a series of webinars in several languages during the course of the year to keep in touch with the evolution of the issues related to COVID-19 and reporting in general, such as vicarious trauma, for example, which has been an important one, but also aspects of different platforms like TikTok monitoring or the fact of reporting on these issues in under-resourced languages. But our approach to mis and disinformation around the pandemic pivoted during the course of the year 2020, and here's how and why. During the summer of 2020, our research team started working on how people are talking about vaccines amid growing concern that dangerous narratives and conspiracy theories may result in increasing vaccine skepticism. So we shifted from seeing COVID-19 as a theme for vulnerable to misinformation to COVID-19 vaccines as a theme vulnerable to misinformation. This piece of research that is on this slide under the surface has identified key vaccine narratives on social media in English, French, and Spanish, which were susceptible to erode public trust in a COVID-19 vaccine and vaccines more generally during the summer of 2020. Here are the 6, let's say, narrative buckets that we found vaccine misinformation was falling into. So we have political and economic motives, safety, efficacy, and necessity of the vaccines, development, provision, and access, conspiracy theories, liberty and freedom, and morality and religion. It turns out that, for example, while liberty and freedom is a major narrative around vaccines in English-speaking social media, we did not see it at all in Spanish-speaking conversations, where morality and religion was the main focus. So there is really a difference from one language to the next, one country to the next, in terms of the themes that are related to vaccine misinformation. During the fall of 2020, we started to be contacted for training and research by new audiences, new for us, health specialists and communicators, UNICEF, for example, with whom we have been looking at vaccines more generally, including, for example, the polio vaccine. We collaborated with the WHO to train infodemic managers ahead of the vaccines rollout of 2021. And I have to say that we learned a lot from these new audiences. And I want to say that to you today as well, from these public health experts and public health communicators that we have been working with, in terms of what was at stake for them in the vaccination rollout. So building trust appeared as a major issue. as a matter of principle, but also as a ground reality to be able to make their daily work even possible. So our work slowly pivoted from a main emphasis on correcting facts to a focus on building trust. This also broadened the scope of our audiences, from journalists and researchers to all information providers in general, especially in the health sector. And this shift goes along with the idea of developing pre-bunking rather than focusing solely on debunking. So what I mean by that is also identifying data voids, which are areas that lack reliable information and are thus vulnerable to misinformation, but also produce reliable content ahead of people's questions. This approach also allowed us to have a more intersectional view on themes and narratives, as well as a cross-border and cross-language scope of analysis. So we created a new online course delivered in live in 9 languages during the spring of 2021, and it's still online. I will share the link with you to adapt to this new broader focus around vaccines and misinformation and the information we can provide about it. This course is shorter than the first one on covering coronavirus. It is in bite size, adapted to people, as we said at the beginning of this event, people who now have been working from home for more than a year or have been online on a lot of Zoom conferences and sessions. So it is also looking more at the information we create and how this information can generate trust, rather than keeping the main focus on the information we verify. It involves sessions, for example, on how to avoid the amplification of misinformation. It also shows how to identify these data voids that I was talking about. It has tips to deliver content in a more responsible way and reliable sources of data and information. So building trust when it comes to vaccination rollouts, as you know, is a key issue. Let me just illustrate this by a case study that we published at the beginning of 2020 around the polio vaccination campaign in Pakistan. So there had been a big effort done by international NGOs and Pakistani authorities to vaccinate people against polio, especially children. And that effort was going okay. And then in April 2019, trust in vaccination broke down. In large part, that was due to a series of rumors, some taking the form of misleading videos saying that children were having an adverse reaction to the polio vaccine. By analyzing social networks and Google searches, we found that before the misleading videos, polio cases had started to be contained, and then spiked again at the moment these videos were shared. But a key bit of historical context is that in 2011, allegations surfaced about a failed vaccination effort on the part of the CIA. So what seemed to be a vaccination campaign against hepatitis B in 2011 was actually an attempt to collect DNA information about the Bin Laden family. It sounds mad, but it turned out to be true. So to put things into perspective, this happens in the same region, as you can see near Peshawar, where the confidence breakdown happens around the vaccine years later in 2019. What gives misinformation power, what makes it work, is that it often has this kernel of truth. This is why building trust should be an absolute priority. Narrowing the problem to just misinformation really misses the big picture. Now, I just want to end this presentation by sharing some additional resources with you. So we just released a new report, a new research report yesterday. It looks at the way pro-Russian and pro-North American anti-vaccine narratives have been emerging and circulating in Western Africa ahead of the launch of vaccination campaigns. It's a very interesting report. I can only encourage you to have a look, and I will share the link with you. Normally you will receive it in the wrap-up email after this event. Here are also some of the links to the work we have been doing around vaccines and misinformation, the trends we see emerging at global and regional levels that we share, but also our multilingual training resources. So you can find all of that on the first links on Vaccine Insights. And the second link is a quick PDF guide to responsible vaccine reporting. So that's it for now. Thank you for your time and attention. I'm available for questions afterwards. And as I said, if you are interested in any type of collaboration or training, do not hesitate to get in touch with me after this. Thank you.
Marie, thank you. It's a wonderful overview of the work that First Draft has been doing, and in many ways indicative of the work that's happening across this space with multiple stakeholders that you're talking about. I'm hearing several things coming up from both panelists already, this idea of developing and conducting courses that are building skills, but skills that can do more than quality check news. There's skill building around or thinking through strategically means to build trust as a way to pre-bunk or improve the quality, as a way to precondition almost the audience to better understand and identify effective resources and effective sources of information, and critically risky information or low quality information that may threaten discourse in civil society. So thank you for this, for your talk. It's a nice compliment to Dr. Mbeva's presentation. Our final panelist today is Kaleem Khan. He's the Nigeria Country Director for BBC Media Action. And BBC Media Action brings a focus on international development to bring a focus on communications and international development. And we're very keen to hear what they have to say around public health, behavior change, communication initiatives that can increase awareness of routine immunization, thinking about drawing lessons from polio, and then also the implications for where we're at now with COVID. So with that, Kaleem, I'll turn it over to you. I'm curious to hear what you have to say.
Thank you, Ben. If you please just bear with me while I share my screen and just let me know if you can see.
It's coming through. Looks good.
Okay, great. So, hello everyone. My name is Kaleem Khan and I am the Country Director in Nigeria for BBC Media Action. BBC Media Action is the BBC's international development charity. We believe in media and communication for good. We reach more than 100 million each year in some of the world's poorest and most fragile countries. Our projects and programs save lives, protect livelihoods, counter misinformation, challenge prejudice, support accountability, and increase participation. Before I get into a little bit about me, over the last 5 years, I have been fortunate to work with BBC Media Action in 3 countries and 2 continents on specifically media interventions in public health communications, as well as governance and other resilience type projects. First, in Afghanistan, we implemented a media intervention that sought to increase uptake of routine immunization, including polio. We focused primarily on radio because that has the largest reach in Afghanistan, with the ability to reach the most marginalized. We produced and broadcast a weekly radio program on child health that reached 20% of adults in Afghanistan, and a long-running radio drama that reached 30% of adults. Moving into Sierra Leone, we were working on a comic relief funded project to use media and communication to increase healthier behaviors and treatment to prevent malaria. We produced and broadcast a weekly radio program and humorous, creative, short TV and radio skits. Our research there showed us that regular listeners were 40% more likely to use insecticide-treated bed nets, and 55% of regular listeners said they have started encouraging someone in their family to sleep under a mosquito net as a result of listening to the program. So in Nigeria, where I'm currently working as the country director, we have worked on a UNICEF-funded media intervention that aimed at preventing deaths and paralysis by preventable diseases, including polio. We produced and broadcast a weekly drama in local languages and a series of TV and radio skits. We conducted quite advanced statistical analysis on the research for that project, and regression analysis showed us that those who are regularly exposed to the program were 3 times as likely to say that their children or grandchildren were immunized compared with those who did not listen regularly to the program. And those also regularly exposed to the program were 2.7 times as likely to say that they allowed their children to receive polio vaccinations every time it was offered, compared with those who did not listen regularly to the program. In August 2020, Nigeria was officially certified free from the wild polio virus after marking 3 consecutive years since the last case of wild polio, and we were grateful to have played a part in that effort. More recently in Nigeria, we have been working with WHO to create a social research tool that can be contextualized to suit country needs for data collection during the coronavirus pandemic. The tool was co-designed by BBC Media Action, WHO HQ, and the country teams of both WHO and BBC Media Action. In February 2020, when the first case of COVID-19 was reported in Nigeria, it was a very daunting and uncertain time. The government of Nigeria responded quickly with an unprecedented stay-at-home order in several Nigerian states. The lockdown order immediately put the livelihoods of millions of Nigerians at risk. At the time, there were only 131 confirmed cases and 2 reported fatalities. And for many, it was hard to understand why such action was necessary. Meanwhile, misinformation and disinformation spread across the media like wildfire. The UK Foreign and Commonwealth and Development Office, the FCDO, funded us at the start of the COVID-19 pandemic to pivot our existing national brands that have significant reach towards a multimedia intervention that sought to increase adherence to coronavirus prevention and mitigation measures, as well as providing a national space for Nigerians to engage on the social and economic fallout of containment measures, plus emerging governance and accountability themes such as voting safely during a pandemic. This is the project I would like to speak to you a bit more today. And just to, by way of a snapshot, you can see here that we pivoted our weekly radio programs for the 2 majority languages, Pidgin and Hausa in Nigeria. Following strictly the most up-to-date COVID-19 precautions, we produced a series of public service announcements that use creativity to cut through audiences' COVID-19 fatigue. We interviewed and featured health experts, health workers on the front line, COVID-19 patients in isolation and those who had recovered, community leaders, politicians, CSO representatives, religious leaders, and of course, regular Nigerians across the country, providing them with a national platform to share their experiences and ask questions directly to decision makers. We took extra care to be inclusive and give a voice to the traditionally marginalized audiences, such as people living with disabilities and older Nigerians who are particularly at risk of severe COVID-19 symptoms. During a period of 6 months, our social media content across our Facebook platforms was viewed 13 million times. During the first wave, we saw significant increase in our online audiences since Nigerians were at home, scared, confused, losing income, and of course, they turned to the media. With a ban on domestic and foreign travel, we were not able to travel to our contributors, nor were we able to invite some of our contributors to our studio for recordings, or invite our 131 trainees to Abuja for face-to-face trainings. But despite these restrictions, we innovated quickly, building a Facebook Live studio that allowed us to continue producing programs that bring Nigerians across the country together to give them a platform to question politicians and decision makers. The online town hall meetings included panelists such as the Director General for the Nigeria Center for Disease Control, the NCDC, Dr. Chikwe, who answered questions from a live online audience of ordinary Nigerians. The town hall meetings at different times included stories from people who had recovered from COVID-19. In our audience research, one respondent told us that actually hearing the story directly from someone who tested positive, but actually got treated and became better, it was more real to them than the numbers being rolled out by the NCDC and testified to the existence of the disease. Last but not least, we trained and mentored 131 journalists and producers from 50 radio and TV stations across 10 states in Nigeria on how to responsibly communicate in a public health emergency. Under usual circumstances, we would have invited the trainees to our Abuja office, or we would have traveled to them, but under the lockdown, this was not possible. So we conducted the training and mentoring entirely remotely, which was a first for us. The 131 journalists we trained and mentored produced and broadcast a further 228 programs that were broadcast on their local radio stations in hyper-localized languages. At the outset of the pandemic, journalists were as scared as anyone else. They were susceptible to misinformation and disinformation. The situation was unclear and government advice was changing frequently. Journalists and producers were suddenly forced to become experts on the coronavirus whilst they themselves were scared and confused. The trainings and mentoring gave them the technical knowledge and the communication skills to confidently communicate to their audiences in a public health emergency context where the situation is uncertain and events are unfolding in real time and the context is ripe for the spread of mis and disinformation. My favorite quote from one of our trainees, Toloyimi Stevens, a producer and presenter from Radio 1 in Lagos, she says, and I quote, "After the training, I was delivered from fear and I was able to pass that same feeling to my audience." I think this sentiment was shared across other trainees, and I would say it was one of our biggest successes in this intervention. Our capacity strengthening of local media led to better local programs as observed by audiences in qualitative audience research. Audiences of partner station programs noted more insightful programming, better presentation styles, and inclusion of more local voices and experts on the programs, including young people and women. This slide shows a snapshot of our research findings on our COVID-19 response. Not only did the audience say they learned a lot from the programs, but they were also able to list unprompted specific actions they took as a result of listening, like social distancing or shielding vulnerable people, including people with disabilities and the elderly, which was encouraging for us because those were actually our communication objectives for the programs and the trainings. Through this project, we've learned that audiences engaged most with content that was authentic to their lives and experiences. They appreciate content that is in their local languages. Whilst they want to hear from credible health experts, they also appreciated hearing from people in their local communities and from a wide range of voices. Audiences are more likely to believe something told to them by someone they can relate to. And of course, as we've all been mentioning today, trust is incredibly important. And fortunately, the BBC has considerable trust in Nigeria, from being here for quite some time. And also, the reputation of abiding by editorial guidelines is still, gives us a boost in confidence and trust, which was absolutely vital, I believe, for us to be able to build that trust amongst the public. Trust in government, obviously, in Nigeria is a very big issue, and that seems to stoke belief in conspiracy theories. In our survey, we learned that more than half of people, 55%, believed in at least one of the falsehoods put to them, including that COVID-19 had been defeated, that it was a plot to divert money, that it was a disease of the rich, or that it's not real. Worryingly, 16% believe that COVID-19 is not real, which equates to approximately 19 million Nigerians. And I think that this number should perhaps help us to contextualize the scale of the vaccine hesitancy issue in Nigeria. In terms of our learnings here, in March this year, the government of Nigeria expected to receive 84 million doses of the AstraZeneca vaccine from COVAX this year, enough to inoculate 20% of the population. Currently, only around 4 million doses of the AstraZeneca vaccine have been delivered to Nigeria through the COVAX facility. With the arrival of those vaccines, we saw widespread vaccine hesitancy, even amongst healthcare workers who were refusing to be vaccinated. The misinformation and disinformation around COVID-19 and the vaccine persists and is no doubt fueling vaccine hesitancy. But also Nigerians have genuine concerns about things such as cold storage of the vaccines, how the government is ensuring quality. And they are worried about the stories emerging of blood clots and stories of people experiencing symptoms after being vaccinated. So just to conclude on some of the learnings that we feel can be taken forward on building public confidence in the COVID-19 vaccine, we think it's very important, as we've learned, to use personal stories that are relatable. Those are the most effective at building public confidence and trust. As I've said, the distrust in government is high. People want to see people like them who are at the time who had experienced COVID and who had recovered, and they wanted to hear from people like them who had perhaps had the vaccine and was fine and safe. So we also think that the use of creative content, perhaps humor or innovative ways of approaching a story, can help tackle COVID-19 fatigue. We experienced COVID-19 fatigue perhaps 3 to 4 months into the pandemic, and here we are still over a year on, and the fatigue must be building. We also know that we should use media as a platform for ordinary Nigerians to engage with decision makers and leaders. As I said before, there was a unique opportunity during the lockdown with millions of people at home, forced to be at home, and we could see media consumption levels going through the roof, even on our platforms, and also all of our partners were saying the same thing. And it was important, I believe it's important for us to use that platform to continue to engage Nigerians and connect them with decision makers and leaders. So as I say, discussion and engagement are absolutely key to behavior change. So it's essential for us to stimulate the discussion. And I believe that's something that we have done and we will continue to do. One of the specific things we've noticed here is that we should have open conversation about the possible mild side effects of the vaccine. When the first batch of vaccines were being rolled out here in Nigeria, people were very much affected by stories of people having mild symptoms. And from my understanding, this was very common, and it was something that was to be expected in a sample size of, say, 50 people. We saw, at least in our office, this is anecdotal, we saw at least 5% of some sort of mild side effects. And that could be very worrying to people if they're not expecting it. And it could cause them to make claims such as the vaccine is making people sick. And it can even play into mis or disinformation about the vaccine being some sort of attempt to kill people in Africa or any other such conspiracy theories we've heard around the COVID-19 vaccine. Last but not least, I think we should be tackling disinformation head on, again, considering pre-bunking. And again, in order for us to do this, we need to build trust. So the trust is absolutely key. And I think building trust takes time. It takes a history of disseminating accurate, timely information, not stoking people's fears, but instead providing information in a way that doesn't cause panic, even when facts are unknown to us and the situation is unfolding around us. So I think for me that those are the kind of top line takeaways. And on that note, I'd like to say thank you very much, and back to you, Ben.
Liam, thank you very much for that presentation and perspective on the challenges that misinformation have presented, not only with the current COVID pandemic, but thinking more broadly about polio and past infections and epidemics that we've been dealing with. It's misinformation has been around as long as we've needed high quality information. There's been threats to that with misinformation. I like the point you made about misinformation running rampant. The speed, the velocity at which it can transmit is in its own way a public health threat. And so prevention is often better than the cure. If we can prevent or effectively inoculate a population against misinformation before it becomes an issue, you can in effect get ahead of it. And if you, and so that this focus on prevention being better than treatment is, of course, a classic public health principle, and one that makes a lot of sense in a context where misinformation can pass so quickly. I wanted to now open this up to Q&A. We've got some questions that have already come in through the chat, and I'll begin running through those. If there are additional questions, please add them to the chat. We'll collate and take it. Given the number of participants on the call, I don't think we'll be able to take any audio questions. So just feel free to write them in on the chat channel here, and we'll go from there. But I wanted to begin with asking all three panelists to reflect on, and Kaleem, your final slide did this to some extent already, but I wanted to think about what role or what key takeaways you'd recommend around messaging, what kind of messaging is most useful to promote that confidence. We hear about the risks, we've seen the measurement, the degree to which misinformation and distrust can be an issue, but then how do we effectively intervene and build that in a way that that can see vaccine confidence be strengthened? We've heard about generally these approaches, the need to build trust, but what kind of messaging specifically would be useful? And I wanted to begin with Dr. Mbeba, if you could begin with your thoughts on what's worked effectively in the last, say, 12, 15 months to strengthen that confidence that vaccines are effective, beyond COVID, thinking about in routine immunization spaces. What specific messaging approaches have you found to be effective in dealing with that? And then Marie and Kaleem, you just gave that in your final talk, but maybe a few additional thoughts here and get the two panelists speak. It's Dr. Mbeba.
Okay, thank you so much for your question, and thank you so much, Marie and Kaleem, very, very interesting conversations and presentations that I found very informative. I think from my experience and what we've seen is that the messages must be very clearly targeted. You really have to target the audience you are. I think previously our biggest mistake was that we would make one general message for all people, and we thought that that was effective, but our experience has taught us that it's actually not effective. You must target the audience very, very specifically. And the other thing that I've learned is that they have to be very simple, very clear, and very deliberate. I think our earlier venture into advocacy in terms of messaging, particularly to communities, we made mistakes because we kept our messages very general and scientific, but that didn't do it. It just didn't do it. So we've now learned to make sure that we send a message that is very, very simple. We'd rather communicate only one thing, like the number of doses. How many doses do you need to get for this vaccine? I mean, it may sound a very simple question, but it is actually not that simple. And part of the people are asking us, why do you want to give us a vaccine that will need 2 doses, when yet we are being told there is a vaccine that is 1 dose? So we know that the Janssen vaccine is 1 dose, single dose, but the AstraZeneca is 2 doses. And the question has been very simple. Why do you want to give us 2 when there is an opportunity to get 1? So we decided that we'll message one particular aspect of information at a time, and we'll make it as simple as possible. And then the other thing that we learned about messaging is that leverage on people who the communities listen to. Now in Africa, and particularly in the area where we work, there are chiefs and kings and kingdoms. And the people seem to listen more to those than to anybody else who come with a message. And when we were facing a bit of problems with the messages, we realized that the people around Uganda and around Kampala trusted their king more than they trusted the president. And so just having the king getting the vaccine on his arm and taking a picture, he didn't say a single word. He just got the vaccine and he held his card in the hand. That helped to drive a lot of people to the facilities to go and get the vaccine. So do we need to use the optics? Do we need to use a radio clip? Do we need to use a local musician just saying vaccines are safe? Only that, you know, as part of doing his other things, launching his song, but in the process, just rallying people that you need to go get the vaccine, this disease is dangerous. And that has really helped us to push the message forward. So it's about the quality and the focus of the message more than anything.
Great. Now I'm hearing simple, clear, deliberate, granular, keeping it precise, but also not only the message, but the messenger becomes very important. Marie, you have some thoughts on this?
Thank you very much. Yeah, I think that the question of the messenger is definitely a question that we have been looking at as well, in terms of when you talk to communities. We have seen that misinformation circulates much more when the misinformation is related by influences in the communities, whatever these influences are, and if it's on social networks or in real life, we see that these messages have an impact. So we need to use the same messengers or different ones to make sure that we reach out to the communities as well. I think that one other important point for us has been the question of empathy and the fact to avoid ridicule. When we are talking about conspiracy theories, for example, we have seen a lot of headlines, especially at the beginning of the pandemic, about with derogative language saying, oh, you know, this crazy theory saying that this and that about COVID-19, for example. We strongly believe that we need to avoid ridicule, especially in the media, when we are talking to people about people who might be inclined to believe one theory or another around COVID-19, and much more listen to why they would be inclined to believe that theory rather than making fun of them, because that actually has a backfire effect in terms of worldview. So I think that's a major point as well. And then we can find the same effect we saw a lot in the coverage at the beginning of the pandemic as well, in terms of the images and the headlines that were used generally, that were fear-mongering, for example, or that could be divisive in terms of populations. We have seen at the beginning of the pandemic in the Western media a lot of images using Asian people with masks when talking about COVID-19, which has been creating a lot of potential racism and division in the society. So that's also something to be careful about when it comes to media and reporting around COVID-19 and the vaccines particularly.
Marie, I mean, that last point, Kaleem, it reminds me of what Kaleem said earlier about using content or personal stories that are relatable. That, and it speaks to Melandi's point as well about influencers who I trust, people who in my context who I know and have faith in a sense. Kaleem, would you add anything to the recommendations you gave on your last slide?
I think it's important for us to notice, as we were saying, that it's important to understand the audience, and this is the first time for a lot of Nigerians that they would be receiving vaccinations as adults. So there's a slightly different mindset to say them being asked to or encouraged to vaccinate their children before the age of 5. So I think that's something important to consider. It's a different mindset, and it may require a different approach. Also, I can't emphasize how important it is when dealing with public health experts to identify ones that don't can talk without using complex jargon that, you know, our audiences just absolutely will not be able to understand. Often, you know, our audiences may not have even a basic education in biology or science. So if you use certain words, it will be completely over their head. And then there's the issue of translating those words into Pidgin English or Hausa or any of the other various languages here. So I think it's very important to think about the way you approach different audiences.
I mean, there's two things I want to pick up from that real quickly. And one is equity, this idea that we need equitable access to information, that there may be a hierarchy or networks of influences that we all tap into or are connected within, but we want as broad a reach, as equitable a reach of high quality information, sort of inoculation or pre-bunking to reach as many people as possible, to be effective at the end of the day. The second point that comes to mind comes out of the chat where they were asking about with training journalists and training the applied space around information generation and dissemination, this distribution that journalism represents. Are there examples that each of you have? Have you seen cases where there's been effective integration between journalists on the one hand and the scientific community on the other? Are there case studies or examples that come to mind where you've seen this done well, where we avoid the jargon, where science is effectively translated not only across knowledge domains, but in some cases across languages as well, where you've seen that sort of science distribution, if you will, parlayed well or conducted well within journalism? Are there examples where you've seen training programs or case studies execute or deliver well on that? So I'm getting, there's two different ideas, but they're related. This idea of being effectively distributing or equitable in information distribution, but then also on the training side, getting science into journalism or vice versa, bringing a journalist perspective to science. If you have an example that you could give our viewers today of where they might find these case studies, that would be very helpful. So I'll start with Kaleem and then we'll work our way back. Yeah.
Sure. So it's a very interesting question when you talk about the equity of information. And, you know, already in Nigeria, there is a segregation on the equity of information. Not everyone has access to social media or the internet. Radio tends to have the largest penetration, which is why in Nigeria we favor radio. So, you know, the platforms by which you use determine the equity, the languages with which you broadcast or produce content in determine that as well. But just in terms of a word of caution, when we're pre-bunking or debunking mis and disinformation, there is a tendency to give fringe conspiracy theories a platform by which you can grow mis and disinformation. So for us at BBC, we get taught, you know, around editorial values and how to balance those things. It's subjective many times, but I feel that that's something important to note. And just briefly on the second point, when we're talking about cases of success, certainly I would say the more recent experience we have here in Nigeria that I spoke about in my presentation of the polio vaccinations. I mean, any researcher will know it's not always easy to attribute certain action to yourself, but as I showed in the regression analysis, showed a very strong content, a link with viewing and you know, action. But we wouldn't say that you know, that was exactly the pathway. And I think that there was other partners as well working on the same thing, also funded by UNICEF and other partners. So I think collectively the success is that Nigeria is now wild polio free. So hopefully, you know, I think we achieved our goal in the macro sense. And we also have, you know, the evidence that we spoke to in the presentation.
Good.
Thank you.
Great. Thank you.
Yeah, so for example, I had an example that I saw in Germany where NDR did a daily podcast with Christian Drosten every morning, especially at the beginning of the pandemic. And I think that they won an award, the press prize, I think, with this daily show. It was one of the shows that were really recommended by lots of the media partners I talked to in Germany, because they thought that this was probably a very clever way to actually give regular updates, but in a very simple way by a doctor. So it kind of created that bridge. But in a general way, that's also something that we want to create more in the future. We see that there is an appetite, especially with COVID, but this appetite was already there before, for journalists to be more in touch with scientists and doctors, to be able to understand the process of science and the complexity of the process, and the fact that, for example, debate in the science world is part of the process, that the fact of not having straightforward answers is also part of the process. To be able to understand that better, and then be able to also relate it to audiences better afterwards. So that's why we are working on this collaborative network between researchers, public health experts, and journalists at the moment, and we hope to have more results on this in the future.
It's interesting to talk about the uncertainty that we have to deal with in reality and the practice of science, right? And trying to convey that uncertainty and the process by which we learn, that there's relatively better insight, or this is a relatively better effect than that, and understanding the debate that's happening in that space is really, that's a very good point. Malini, your work, again, I mentioned at the beginning, but I was struck by your work as a columnist each week, being able to present in your weekly column the insights from your main efforts here in virology. So are there examples where, maybe aside from your own work, or maybe drawing from your own experience, where you've seen this translation between the training around journalism and the effective science communication?
Yeah, especially like for us, and I'll speak mainly like for two countries, for Kenya and Uganda, which are two countries in East Africa that are very closely their neighbors. I do, like you say it right, and for the 12 years now, I've been writing a weekly column on child health in the Standard newspaper in Kenya, which is quite one of the, maybe the second biggest newspaper in Kenya. And what we do is that I've used that platform to try and teach and communicate, especially about COVID and about vaccine and about child health in general. But in fact, I've also been able, myself and several other colleagues, we made sure that we are actively involved in terms of dissemination of scientific information on TV interviews. I think during this COVID period, I've done maybe over 10 TV interviews on different TV stations, just to be able to pass out the message ourselves, and also be able to work together with the media. So they've been very kind to make sure that they provide prime time and the kind of an interview where they ask you questions and you're able to answer, just to educate the public. And it's been on many issues, not just on COVID itself as a disease, but even on vaccine availability. Recently, I was just on a show called Bottom Line Africa, which is an Africa-wide program, and where we're just discussing the issues of vaccine availability vis-a-vis some countries like Malawi, which were already destroying vaccines because the vaccines had expired, and how do countries that don't have enough end up destroying vaccines because of access issues and problems in terms of delivery networks. They were not able to deliver the vaccines in time to the communities that required them for all sorts of reasons, logistics, road transport, and problems like that, and then problems of hesitancy and uptake. And in Uganda, for the last 3 years or so, we've been running a conference together with the media. It's called the Uganda Health Communication Network, where we have an annual conference, a 3-day conference where the media and its representatives meet together with academia and scientists from the universities and just exchange ideas and research work that is going on. And then the media is able to disseminate that. In fact, the last one we held was 25th to 27th May. And I can just read you simply what the provision, the addendum was. They say that the overall objective of the Uganda Health Communication Network is sharing evidence-based research between health researchers, policymakers, and knowledge intermediaries. These are the journalists, librarians, editors, and the rest, and it provides a platform for influencing health policy and practice through research and effective communication. And the network central premise is that greater access to more accurate information leads to better decisions, healthier behaviors, and more effective policies. And this year's annual scientific conference aimed to provide an independent platform for the exchange of ideas, knowledge, experiences on topical issues, and foster health and well-being. And with speakers who are invited from the field of communication and infectious diseases to talk about COVID-19. And it was quite an interesting conference because we had a lot of media personalities across the country and from neighboring countries just discussing issues around COVID-19, how best to report information on the disease, how best to report information on the vaccine, how best to counter negative messages around the vaccine, and how best to engage the public continuously in developing not just trust in vaccines and in treatment options, but also to empower communities to demand for better healthcare. And that is one of the things really impressed upon the media, that we need them to help us to empower our people to demand from the government and to demand from the leadership better immunization, better healthcare, better timely interventions when we have health problems. So I think it's still early days, it's budding, but I think in the next 10 or so years, we should be able to get somewhere in terms of engaging the media and the community and the scientific world.
I wanted to get back to an earlier point you made about targeted messages, having something tailored, simple, clear, deliberate, granular, but targeted. And we talk a lot about social media, and social media is in some ways, or has aspects that are in some ways like mass media, that it's a shared experience to the extent that you're following groups, that you see conversations happening in some sort of pseudo public space on a timeline, which is not unlike the sort of discourse you might have in other public squares or settings. But this targeted messages, if you take it to its kind of the limit, ultimately you're into this messaging space where it's one-to-one and it's encrypted, it's not public. I'm having a one-to-one conversation on WhatsApp, or I'm on Facebook Messenger, or I'm on other Telegram, and having a one-on-one conversation. And yet these ideas that I transmit to one friend or one contact then go out to others, and they may go into a WhatsApp group, but it's fundamentally a one-to-one experience. And in that space, in that kind of context, are there particular strategies you would emphasize? Is it something you would do differently, or is it do more of the same? We've been discussing, we've got 7 minutes here, so I wanted to give everybody a chance to think about, in the sense where the future is going on this, on closed or one-on-one messaging platforms or channels. Are there particular strategies effective in those settings where you're no longer narrating, curating, or having that sort of public interface? You're now fully trusting that the message itself is being transmitted in a way that's relatable, that's reliable, that the clarity and the simplicity is retained. So what do you do to keep those messages simple, clear, and deliberate when you no longer have control of it? And
I think maybe I can first,
please.
Because of my experience with the work at Facebook, and what we've done with Facebook over the last 2 years is we sat down with the whole team and asked ourselves, we want to go to people to take them information and messages, but do we really know what they want? I mean, you could come with your message, but is that their need? Because you can only meet a need. And so you must have seen, if you're on Facebook, some surveys, and they keep, for some people, they ask you, do you want to participate in a survey on COVID-19? Do you want to participate in a survey on vaccines? Initially, people were skeptical, but we are noticing that an increasing number of people are taking up those surveys and answering the questions. We now make the surveys very, very short. We don't want someone to take away somebody's 2, 3, 4, 5 minutes. They may be having maybe only 10 minutes to look at their wall and answer and check out on their friends and something like that. And so what we've done is that first we've done adequate needs assessment. You want to meet a need that is existed in that particular community. Because adolescents and teenagers have a totally different need sets compared to adults and compared to young children who are now also able to access social media. And so what we've done is that first is to assess the need, and once you've assessed the need, then look at which is the best way to reach which community. We realized that the way you reach the adult population, let's say the people above 50, is totally different from the way you reach teenagers and the way you reach adults. So we want to tailor messages based on the age and need. The same message can be packaged in 5 different ways to meet 5 different people. And that's, I think, what we may need to think about. So the adult population, the elderly, may benefit from a clip where they're listening to someone who is an authority, who they know, who they've read about, and who they can relate with. And the younger children may benefit just from a cartoon that passes the same message. These are for kindergarten and younger kids. And then for those who are teenagers, we can have something that is graphic, that is tailored around, maybe around a movie character or something that they can relate to.
Fantastic. We've got 4 minutes remaining. I'm going to give 2 each, Marie, Kaleem. So Marie, please, your thoughts on keeping the message relevant. You don't want to control it.
Yeah. So for us at First Draft, we're more focusing on finding what people are actually talking about rather than drafting the message afterwards. So just about this closed messaging spaces, they are way to make some social listening about, like, to find out what people are talking on these spaces. We have several resources to do that in a very legal way, because there are also illegal ways that we are not covering at all. But we also have some projects where we have tip lines, and that's another good way for people to share with us or with some media partners what they are seeing on WhatsApp, on Telegram, and on other channels in private spaces where we don't have a direct access. And I think that's very important for us, because we know that these conversations are happening, and that's probably where a lot of misinformation can be shared with a will to protect people around people. I mean, not with a way to deceive people, not with the intention to deceive people, but really with this intention to actually protect your loved ones and your family, etc. And so I also have a colleague who wrote a piece, which I'm going to share in the chat right now, on how to talk to family and friends about that misleading WhatsApp message, for example. But we also have some resources about how to look at TikTok and, yeah, as I said, other platforms such as them. That's it.
Thank you very much. Kaleem, final word. You're on mute, sorry.
Yes, sorry. So on the last point about one-to-one messaging, I mean, we know that our social media content, specifically, even our TV, public service announcements, they get shared on WhatsApp, and it's difficult for us, obviously, to track it, but I get them shared back at me often, or other people do. So we know it's happening. You can find out, you know, that it does present all of the issues that I'm not going to go into now, but it's happening, and it's a great source of spreading disinformation. And I guess one of the ways that we tackle that is by training the audience actually on fact checking, on how to, you know, deal with. In fact, we did public service announcements exactly on that. When is it ethical even to share information that you haven't even read the article on, and you know, having an emotionally resonant message that they can connect to. So I think that's one of the key things. One of the things to talk about when it comes to simple and clear messages, the thing about COVID-19 has been that the information is not always, I mean, the health technical information, perhaps yes, but it's been evolving, and we've been learning as we're going. So you have to be mindful that when you tell people, or say the government says something and then it's proved wrong, vaccines are going to be here in 2 weeks and it's 3 months down the line, you know, you're setting yourself up to be distrusted. So what we would prefer to say is how to build the communication skills to talk about things when there is a lot of uncertainty, which is what we're seeing, and not causing panic, and presenting the information for people to make the best decision for themselves. Thank you.
Fantastic. I want to thank you all for a very insightful and energetic and meaningful panel. I learned a lot myself, taking a lot of notes, copious notes here as we go through. So I really appreciate your time and energy on this. I want to thank the core group for convening the panel today. It's been a pleasure to dive into this timely topic. And I will simply close out with just, I think, some key takeaways, thinking about the use of personal stories, getting back to this idea that prevention is better than treatment. We do this, we can do effective prevention with information that's relatable to each of us at the end of the day. And there's more tools than ever and more challenges than ever in trying to make that possible. So I'm trying to make that happen. So thank you all for your contributions, and I'm looking forward to what comes next.